you, and thank you so much for turning up for this most important landmark symposium of the conference, the National Symposium. All the other halls are closed at this point of time, and there's two symposia going on, and this is on infections of the eye. Basically, we initially thought about broad-basing it and covering all infections of the eye, but considering what happened in the past year and the emphasis on cataract infections and endophthalmitis, we decided to focus more on that. I'm just going to give a brief introduction before we start off with the various speakers. Endophthalmitis occurs in the best of hands and the best of setups. I think the only person who can claim to have not had endophthalmitis is one who does not operate. It's almost become a cliche to say this, but it's absolutely true, and all of us know about it. Obviously, these are most serious complications with a potential for great visual morbidity. Thankfully, it is of extremely low incidence, but simply because of the number of surgeries that are performed, especially cataract surgeries, even this low incidence translates into a significant numbers. Worldwide, about 25 million cataract surgeries are performed last year, about 6.6 million cataract surgeries in India. And even if you take an incidence of 0.1%, that would amount to a few lakhs of patients. And obviously, these are patients who are extremely dissatisfied with the outcomes. What is exactly the incidence of this condition? There's various nationwide surveys that are available. It varies from 0.012% in some of the Scandinavian countries to 1.2% elsewhere. Looks small, but you look at this 1.2%. That means almost 12 patients in 1,000 who are getting operated, getting this problem. And often this condition is also grossly underreported. It's quite difficult to get exact statistics of the prevalence. But the very fact that there is so much of variation, there's almost 100 times difference in the nationwide prevalence. So obviously these countries which are having a 1.2% prevalence can do quite substantially to improve upon the prevalence of this problem. There is a decreasing endophthalmitis rates over the years. Meta-analysis has shown that in 1970s it was it was for the same subset of population, 0.32%. In 80s it became 0.15. In 90s it became 0.08. You almost see a 50% drop a decade on decade. Is it further progressing? Why I don't have the statistics for what happened in 2000 is this article came out sometime in the early 2000, and also I do not think there has been a significant drop that has occurred in the last decade. Actually, when the clear corneal incision came by in between 2001 to 2003, there was actually a spurt in the incidence of endophthalmitis, though now it has been brought under control. And again, the impact of endophthalmitis today is far, far more than what was considered to be maybe a couple of decades back, simply because there is so much hype, a little bit of trivialization of cataract surgery. We talk about refractive cataract surgery, tell patients that you can get back to your normal routine the day after, and we operate on patients in their young productive lives in their 40s and 50s, and sometimes with a vision of 6'9", there is an increase in longevity. We operate on patients in 40s and 50s. It's quite common for them to live into their 80s and 90s. So what we do today, the complication that we create today, may far outlive our own professional lifetime, and we have to live with this. And there's much higher expectations. Patients want to go back, resume their activity with perfect vision the day after surgery. So what are the meta-analysis of about 42 studies worldwide has shown these are the major risk factors: extra or intracapsular cataract extraction. Phacoemulsification properly done is supposed to reduce the incidence. Clear corneal incision, as I mentioned, was considered a problem, but today we realize that the incidence between clear corneal incision and scleral tunnel incisions is not very different. Without intracameral antibiotic injection, it definitely causes a spurt in the incidence. If you have complications like posterior capsular rupture, silicone intraocular lenses, intraoperative complications, any intraoperative complication, prolonged surgery. Incidentally, it's also been said that males and old age is also conditions which are where the endophthalmitis prevalence is a little more. So obviously it requires a multifaceted approach, and my panel is going to take you through all of them. optimal OT construction and practices. Where you do your surgery has to be perfect, appropriate prevention and prophylaxis, rapid recognition and aggressive management, availability of improved pharmacological agents and vitrectomy techniques has obviously allowed us to get good outcomes even in these patients who have this severe problem. And then finally, if you do have it, and especially a cluster endophthalmitis, how to deal with it socially and legally. These obviously are the questions uppermost in the minds of any ophthalmologist who is doing surgeries. I have an excellent panel and they are going to take you through all these steps. And I invite Dr. Shashi Kumar to talk to us about fundamentals in OT designing. We don't grow when things are easy, we grow when we face challenges. Endophthalmitis is such a challenge in the life of an ophthalmologist, and let's see how best we can handle this. Thank you so much.
Thank you, sir, for choosing this topic as the National Symposium, because it's very important, and thank you for inviting me to be a part of it. This is a very vast topic, the concepts of OT designing, and it is very difficult to include it in an 8-minute presentation, but I will try to do justice. What I want to highlight is one regarding the location and zoning concept, the walls, the floor and ceiling, the pendants, doors, water supply, electrical connections and ventilations. An OT is ideally located away from the crowded areas, especially where the traffic is more. So it is best to have it in the upper floor, but you should avoid chances of excessive humidity on the walls and the ceiling, and take care when there is a drainage and plumbing lines outside the wall, and also the tree and other foliages. An operating room, in the operating room, the OT table takes about 1.85 meters. The trolley takes about 0.9 meters. We need a working space of about 1.2 meters around that. So an operating room, 150 to 200 square feet is enough for an anterior segment surgery, and about 800 to 1000 square feet for a good small OT complex. We have to concentrate on the zoning concept. Essentially, the OT should be arranged in these zones. It should have a protective zone, which includes the reception, then a clean zone, an aseptic zone, which is housing the operating room proper, and a disposal zone. Why this zoning is that you are arranging the various OT rooms in varying degree of bacteriological density. The aseptic zone should have the least bacteriological density. It is also aimed at having optimum utilization of the staff, the materials and the OT time, and also to streamline traffic inside the OT to avoid mixing of clean and dirty items. We also need these ancillary facilities in the theatre, like the changing rooms, the pre-medication rooms, the store and the sterilization, the scrub area, and the sterile trolley preparation room. If you are providing a toilet inside the OT complex, it should be in the outer zone. This is a 3D picture of an OT layout where the different zones are shown in different colors, and you can see that the operating room is safely located in the sanctum sanctorum. Now this modular OT concept is there, where the construction is very speedy. You get a high quality finish where prefabricated modular OT, it's just a finished steel structure with jointless sterile coating. These prefabricated panels are brought to the operation room and then assembled. It is easy to remodel it also, but it is extremely costly. See, the walls of the OT can be made of tiles, epoxy, vinyl. There are so many structures, materials are there: stainless steel, powder coated GI sheets, high pressure laminates, glass, Korean sheets. Floor also, you have the option of tiles, epoxy, vinyl. But then the problem with tiles, ordinary tiles, is that it will retain moisture. So in a hot and humid area, the chances of fungal growth is more. If you are opting for a false ceiling, it is better to go for a stainless steel or an aluminum composite panel. This is a picture of a OT with epoxy flooring, a vitrified tile on the walls, and stainless steel false ceiling. If you are having a false ceiling, it should be about 11 feet from the ground floor. This is a ordinary cement wall, but coated with antifungal paint, polyurethane paint. See, the walls of the operating room proper should never have a cabinet. If you are providing a cabinet, it should be concealed or it should be flush with the wall. Similarly, the switches also should be flush with the wall. This is a OT with a stainless steel wall and ceiling. And this is glass walls with very eye-soothing pictures you can have. The OT walls should not have it is better not to have a skirting in the OT wall, because this the horizontal skirting will accumulate dust. So if you are providing a skirting, you should have a sloped top. And the essential requirement that you should suggest to the architect is that the floor and the walls should be smooth, conductive, non-conductive, and it should be easy to clean. A right angle is not the right thing in the theatre. So you should never have a right angled corners. It should be curved by coving to avoid corners and the dust accumulation. This is a stainless steel theatre with coving, and this is an ordinary theatre with epoxy coving. Exhaust usually is not allowed inside the operating theatre, especially in the operating room. But if you have many people are providing exhaust in the theatre sterile supply department where the autoclave is kept, this will get rid of the heat and the steam. But then if you are providing an exhaust, it should have a shutter and a box with insect screen. The ideal temperature in the operation room is around 20 degrees and the humidity should be around 40 to 60. Increased humidity will cause fogging of the microscope head, and also the chances of fungal growth will be more. As I said, if you are having a ceiling, if it is a concrete ceiling, it should have antifungal paints. Otherwise, you can have a false ceiling of best thing is stainless steel or ACP, which can provide airtight closure. Ceiling mounted operating microscope will relieve the floor of the clutter of cables and all. If you are providing a manifold pendant, it should be located 60 centimeter from the end of the table and 60 centimeter away from usually at the foot end of the table. And the height of the pendant should be about 6.3 feet above the floor level. There are different types of service pendant to provide gas outlets, electric outlets, the medical air, and it comes in different designs like fixed length, telescopic, rotating, like that. The main door of the OT should be about 1.5 meters and 7 feet height, with a minimum door opening of 90 centimeters to provide hygienic entry and exit of the scrub person and the trolley. A swing door will displace more air, but a sliding door will produce least air turbulence. This is a swing door, stainless steel swing door, and this is a swing door with high pressure laminate. This is a hermetically sealed sliding door with an infrared sensor. OT door should have vision panels, otherwise people will keep on opening the door to see what is happening inside, even the OT staff. And one should never have many doors in the operating room as well as the OT complex. There should be barriers between the operating room and the outer zone to reduce the contamination of air. Electrical connections, at least 4 to 6 duplex sockets should be provided near the head end of the table with adequate number of UPS sockets for your phaco, the vitrectomy, the patient monitors. And one should have a generator, appropriate generator backup also with proper earthing. You should provide clean running water in the OT. The final hand wash can be with filtered water or boiled and cooled water. Nowadays, these stainless steel modular scrub stations are available. One should periodically monitor the OT water. This is a stainless steel scrub with knee-operated controls. This one is with infrared sensor. And this one is with a manual, elbow tap. See, the height of the scrub station should be about 96 centimeter from the floor, and another 25 centimeter above should be the water outlet. Air conditioning is not just cool air. It is control of temperature, humidity, pressure, air exchange, cleanliness, and order. And we can achieve these objectives by filtration of air, dilution of contaminated air, maintaining positive pressure inside the OT, providing laminar flow, and by providing the controlled temperature, humidity, and ventilation. We have several options for that. The window AC, the split AC, both these are not recommended in the operation theater. The other option is direct expansion. That is a ductable split AC, which is costlier, but this provides, here you can have a control of all these parameters. And the best is a centralized AC with HEPA filter, but it is extremely costly. It is better to have an air handling unit in the theater, which provides 3 filters, a 20 micron pre-filter, a 5 micron microwave filter, and then a 0.3 micron HEPA filter. Actually, NABH recommends AHU for the OT with the pre-filter, the microwave filter, but you can stop. Just 2 more slides, sir.
Okay, please go.
But HEPA filter is not mandatory for NABH. This is a HEPA filter. This is a VLF with a HEPA filter. This is the other option, that is a fan-powered HEPA filter, which just provides filtered air only. The NABH recommends 25 air changes per hour. And to conclude, the OT should be tailor-made for every situation. There should be a good understanding between the architect and the doctor at the beginning itself. And it is better not to remodel an existing eye setup and never share your IoT with other people. And ultra-clean OTs are ideal, but even conventional OTs can be kept clean by religious attention to proper disinfection protocols. Thank you.
Respected chair people and my dear friends, thanks to all those people who are here for having selected this topic for the National Symposium. I'll just show you a small video to begin with. You may have wonderful OT, but tomorrow when you go back to the OT, do this work. Any small horizontal surface, you pick up a wet, moist cotton and run on it. If you see dust, your OT is not perfect. It's not just the structure that's important, it's the function that's important. It has to start from your outpatient department. I have no interest conflicts in this presentation. Way back 1,500 years ago, Sushruta said, who is the father of eye surgery, certain things are very important, which includes hygiene and fumigation. The moment you go back to your theater, you have a wonderful theater, but you don't have a team. You have to have specific infection control team set up, which consists of a nurse, a doctor, and orderly, or the entire vertical have to. These are the functions that are there for them, including the waste disposal, monitoring staff health, and investigation of a breakthrough. All that has to be looked at by this particular team. They have to be earmarked, they are specific, they have to meet periodically. We all know that the sac, when it gets infected, occupies an anatomical position, but when you want to do a rope loss, that's not the place to press. You'll have to go behind the anterolacrimal crest, press on the medial canthal ligament or below that, and then look for the regurgitation. A lot of people press here on the side of the nose, and nothing happens. You take the patient to the OT, he may have a minor infection in the sac, and then it'll come back to you as the infection. Preoperatively, diabetes and other diseases have to be ruled out. Eye drops has to be started. I start ofloxacin eye drops. That's my priority, 2 days before the surgery. And patient has to be educated how to use the drop. This is one of the most important things that he should do. Give a demo, and the family person has to pick up drops, open it up, and put the drops himself. That's important. Small things are very important in prevention of infection. The patient has to shave and head bath and wash face. All of you do it. But the moment he comes into the OT, he has to wash his feet. So he walks everywhere and comes to the OT and walks into the OT. And washing feet is one of the important protocols that he should develop. The moment he comes, we put a drop of paracaine into the eye. 5% povidone iodine, close the eyelids for full 5 minutes. Don't do anything. Just let him meditate. Then you start doing dilatation. So by then 5 minutes, betadine would act everywhere in the conjunctival sac and keep it disinfected. Don't do any investigations on the day of surgery. This has been covered. Let me not duplicate the efforts. One of the most important is to maintain the low humidity in the operation theater. Water has to be clean. It doesn't have to be sterile. Draping has to be perfect, as you can see here. And betadine I've been using since 1987. It is a compound of povidone, which is a synthetic polymer, and active iodine. By and large, betadine itself is very poor disinfectant. But when the iodine gets released from the molecule, it acts. Iodine gets released only on dilution. So 10% is not the best. Go for 5% or even more diluted ones. They are much better because elemental iodine gets released. You have to wear proper attire in the operation theater. Your skin releases 10 lakh squamous epithelial cells. Each one of them is a potential rider for staphylococci and enterococci. They are shed throughout the day and night. And a small pinhead area may have 1 crore bacterial elements there. So they can double in just 20 minutes, and 90% of them are eliminated with just a hand wash. So good hand hygiene is very important. Not only you do a good hand wash, but it has to be dry. The wet hand sheds about 60,000 particles, while if you have properly dried the hand, 200 bacteria are alone there for dissemination. So improperly washed hands and residual moisture, both of them are the causes for the contamination of the environment. Put up these charts everywhere in the operation theater, wherever the wash basin is there. When you wash your hands, social washing, see that the back of the hand, tip are not clean at all. These are the areas that you never clean them. The entire thumb on the back side is not clean. So specifically look for them when you do this. You can keep these gloves everywhere. These are very cheap. Each gloves will probably cost 2.5 rupees. Keep it everywhere in the OPD, and you just wear it whenever you want to touch the patient, whether it's doing a roplas, lid or eye touch, or these are unsterile, just like your tissues. They're available in the market. Scrubbing has to be good. First scrubbing can be 10 minutes, and after that you can, alcohol rub is fine. Glove wearing is a specific way. You'll have to learn that. Fluids, wash the fluid and discard the gallipots totally. There is no place for this in the operation theater. And we store the used bottles at least for about 3 weeks' time after the surgery. If they get contaminated, we are very careful. Check the label of the bottle ampules. And these cables, these wires which go in and out, you'll have to be very, very cautious. Stick them with the adhesive tape so that they don't go in and out. You cannot reuse instruments. We have a protocol. Entire cassette and the phaco tube goes to the autoclave and comes back for each case. If it's SICS, it's very easy. That's all the instruments you need. I don't use boxes. Instrument cleaning has to be perfect. Whether you've used or not, it has to go through the ultrasound bath, and instruments have to be washed thoroughly. Surgical tubings have to be discarded because there's a biofilm which accumulates inside that. And you monitor your autoclaving. This system, small gadget, is very useful because the veracity of the electrical losses, electricity cutoffs, they can be covered by them. Sterile packs, you have to manage them in a proper way. You cannot, once they are sterile, they can easily get contaminated by even a little drop of water falling on them. So you'll have to be very, very careful. Disinfectants are actually used in excess. We don't need so many disinfectants in our operation theater. What we need is hygiene and cleanliness. Avoid formaldehyde of all types. Formaldehyde as well as glutaraldehyde has to be not used. There are very good non-aldehyde disinfectants available. They are the ones which has to be used. And mopping is much, much better than using, disinfectants. Simple detergent, just hand wash with ordinary soap, not even a Dettol or disinfectant soap. That reduces the flora on your hands by 80%. If you use a disinfectant, the add-on is only 15%, 95%. Floor, only 1% of the bacteria are pathogenic. So a lot of importance is given to the air, floor, walls, ceiling, but it's actually we are overdoing it. That's the best way is to clean with detergent, not with disinfectant. Reduce bioburden. Do not dirty it, thinking that anyway I'm going to send it for autoclaving, anyway somebody is going to clean it. So dirtying has to be minimal. Never reuse the syringes. Minimize, don't bring flowers to the hospital. They are the highest contaminating things, fruits, food edible. In our hospital, nobody can eat food in the hospital. No biscuits, no coffee served in the OT floor. Clean and dry, that's the, as I already said, biomedical waste has to be segregated. There are a lot of information available there. So basically you need to have a daily protocols, which just means cleanliness of the operation theater. Alcohol spray can be used for the handles and your structure, and clean sinks and footwear everywhere. There is a weekly protocol which depends again on the OT setup that you have. So microbial surveillance is not needed. Everybody does, many people do weekly or monthly or 3-monthly culturing of the OT. It is just not needed. The modern OT does not have a surveillance. Whenever there's an increased, I'll just take 2 more slides. Whenever there's an increased infection rate, or when a civil, carpentry, electrical, plumbing, any work is done, that's the time you have to thoroughly clean the eye and monitor the microbiological survey. Otherwise, it's not. Anaerobic sports, there is no need for surveillance of anaerobic sports. Supplies has to be very good. You'll have to be very, very careful when you want to buy something, and buy always something from a trusted supplier. By taking OT maintenance is logical. Just have a thought. Just keep your eyes and your logic working, and you will find out a lot of ways by which you are doing errors in the operation theater. You can control it. We do a lot of video recordings of our surgeries. Tomorrow when you go back, ask somebody to have 2 mobile cameras and record the entire surgery, what happens before and what happens after that, and go back at home, leisurely watch it. You will find out hundreds of ways by which you could improve. Thank you.
Thank you, Dr. Ravindra. That was a very nice the OT techniques to avoid endophthalmitis, including the classical hand wash and other things about that. You don't have to scrub, you have to mop the floor, use sodium hypochlorite. And now we'll come on to prophylaxis of endophthalmitis, which is extremely important topic. And we'll have Dr. Shreyas Ramamurthy from Coimbatore, who will cover this important topic of prophylaxis to prevent endophthalmitis.
We have about 15 minutes at the end of the session for discussion. I think we would encourage questions from the audience. Please get ready for that.
Thank you, sir. Good morning, everyone. And while I begin to talk on this topic of prophylaxis of endophthalmitis, the first question we need to ask ourselves is, do we really need prophylaxis to prevent endophthalmitis? It is my duty today to give you an objective answer for this particular question from the existing body of literature. The incidence of endophthalmitis today stands anywhere between 0.03 to 0.2%. And if you look at longitudinal studies which have been published, with better sterilization practices, there was a steady decline in the rate of endophthalmitis right up to 2003, dropping to as low as 0.128%. But then around 2003, with the advent of clear corneal phacoemulsification, there was a spurt in the endophthalmitis to up to 0.29%. This gave rise to the need for a prophylaxis. Something which has now come to stay is the advent of povidone iodine for the use of prevention of endophthalmitis. But then there still seems to be a certain amount of controversy as to what route of povidone iodine do you use. Do you just use it for periorbital cleaning? Do you instill a drop on the conjunctival sac? Or do you do an irrigation of the conjunctival sac with 10% povidone iodine? Now, this was a particular long-term study published a couple of years back, which gave excellent input into this thought process, where they showed that there was an endophthalmitis incidence of 0.338% when there was no use of betadine or povidone iodine. But then, when they started using a drop of povidone iodine, it did decline further. But then, when irrigation of the conjunctival sac with povidone iodine, they had a remarkable improvement with a drop in endophthalmitis rate to as low as 0.04%. Then came the question of using perioperative antibiotics. Though topical antibiotics are used widespreadly and likely to remain so, but after the advent of intracameral antibiotics, it is quite easy to understand that intracameral antibiotics achieve far higher MIC levels than any other route, be it topical or subconjunctival. So therefore, the use of topical antibiotics is slowly becoming questionable. Now, what are the intracameral antibiotics we have available with us today? The three major ones remain cefuroxime, vancomycin, moxifloxacin. And the remainder of my talk, I'm going to focus on these intracameral antibiotics and try to give you an objective answer as to what we can adapt into our practice. The first being intracameral cefuroxime, which is a beta-lactam antibiotic. It has excellent gram-positive coverage, but then the gram-negative coverage is quite moderate, and it has almost minimal efficacy or no efficacy against Pseudomonas. It is used in a standard preparation of 1 milligram in 0.1 ml. Now, there have been a number of studies which have shown a 4 to 10-fold reduction in the incidence of endophthalmitis with the use of intracameral cefuroxime. But I would like to turn your attention towards a landmark trial, which is the ESCRS study, where they had 4 groups divided in a prospective manner, where you had group A and C here, where they did not have any intracameral antibiotic administered. In group A, there was no perioperative. In group C, only topical antibiotic was used. In group B, they had only a cefuroxime, intracameral cefuroxime. In group D, there was a combination of a topical and an intracameral. Now, the results were quite interesting. These are the incidence of endophthalmitis rate. Now, without the use of a topical antibiotic, the incidence of endophthalmitis was quite similar at 0.35 and 0.31. But when an intracameral cefuroxime was added, there was a 5 to 7-fold decrease in the incidence of endophthalmitis. And as you can see from this particular chart here, the additional topical antibiotic really had minimal role to play when an intracameral antibiotic was being used. So to summarize, there was a 5 to 7-fold decrease in the endophthalmitis rates, but then there was one major criticism in the ACRS study. The control arm had an incidence of endophthalmitis of 0.35%, which is much higher than the prevailing rates of endophthalmitis we have in current studies today. How about intracameral cefuroxime in the Indian scenario? A good study from the LV Prasad showed there was absolutely no difference in the incidence of endophthalmitis when they looked at it in a prospective comparative study. What could be the reasons? Let us look back at the microbiological spectrum of the organisms causing endophthalmitis in our country. Comparing it with Western literature, we have a high percentage of gram-negative organisms causing endophthalmitis as opposed to as low as 6% in the Western world. This could possibly be the reason of reduced efficacy of intracameral cefuroxime in our setting. So therefore came the advent of intracameral moxifloxacin, a 4th-generation quinolone, and this has wide spectrum activity against both gram-positive and gram-negative. And the advantage is it is preservative-free, it is commercially available in our country, does not require any reconstitution whatsoever. Though there is an increasing body of literature in the efficacy of intracameral moxifloxacin, I would like to turn your attention to this particular large-scale study done at the Arvind Eye Hospital in Madurai, where they showed that in excess of 110,000 surgeries divided into 3 groups, where they had SICS predominantly performed in their charity practice and predominantly phacoemulsification in the private practice, where they had 3 arms. Now, there was an SICS arm which did not receive moxifloxacin, an SICS arm which received moxifloxacin, and the phaco arm which did not receive moxifloxacin, which was the prevailing practice at that time. Look at the incidence of endophthalmitis in this table here. There was almost no difference between the incidence of endophthalmitis whether it was SICS or phaco when intracameral moxifloxacin was not used. But there was a 4-fold reduction in the incidence of endophthalmitis when it was used, even in the SICS group. The major advantages of this study was that it was a large-scale study performed in an extremely short duration of 14 months. Now, a number of studies which need to accumulate a large number of cases run over a period of years and therefore can alter the demographics, give you variations in infection trends and practices, and therefore may not be suitable for your particular practice at that point of time. So this study achieved a 4-fold decrease in endophthalmitis and also achieved a statistical significance in terms of difference. And this was achieved despite using larger incisions. It was used in a lower socioeconomic group of set of patients. And an important point to be noted, 40% of these surgeries were performed either by residents or fellows who are surgeons basically in training. A cost effectiveness study was also done as a part of this, where they showed that the 30 cases who did have endophthalmitis, that the cost required to treat those 30 cases of endophthalmitis was identical to the total cost of intracameral moxifloxacin used for prophylaxis in the treatment arm. These reports were reaffirmed in a mega study of 600,000 surgeries by the same group, where they showed a similar reduction in the endophthalmitis rate. An additional point which this large study also conveyed was they had about 8,500 cases of complication where the PCR was encountered, and this 8,500 was distributed evenly between the group which received the antibiotic and one which did not. And they showed that there was a significant reduction even in the presence of a PCR. The additional advantage which moxifloxacin has is the dose-dependent toxicity, that at higher doses it has higher MIC levels, and even when the dose reduces after 3 hours of administration in the intracameral space, there seems to be a reduction in the resistance and continues to have an effect. I'll finish in 1 minute. The third antibiotic is vancomycin. Though it has excellent gram-positive coverage, and longitudinal studies have shown 5 to 9 time reduction. Recent reports of this dreaded complication of hemorrhagic occlusive retinal vasculitis, which can lead to bilateral profound blindness, and therefore proponents of intracameral vancomycin who do still use it claim that it's a rare complication and something which was not commonly seen. But then the question we need to ask ourselves, is it acceptable to have a rare side effect for an agent which is already being used to prevent a rare complication? So can we have a middle path where you use it only for high-risk cases when we have a PCR or previous intravitreal injections or in resurgeries? A recent survey taken in the ASCRS as recent as 2014 has shown that only 47% of surgeons, despite the existing body of literature, continue to use intracameral prophylaxis. And some of the barriers to adoption of this universal practice is the lack of an FDA approval, lack of a commercially available preparation, and development of resistance. So to conclude, effective perioperative prophylaxis can definitely significantly reduce the incidence of endophthalmitis, and in our setting at least, moxifloxacin seems to have the ease and efficacy. And in the future, we can look forward to novel drug delivery mechanisms which can increase retention in the anterior chamber, resulting in more prolonged MIC levels, which is what we want in reducing endophthalmitis. Thank you for your kind attention.
Thank you, Dr. Shreyas, for a wonderful presentation and a very showing that very powerful studies indicate the role of prophylaxis. I think we'll have a lot of questions during discussion on this very, very controversial topic. Next we have is Dr. Rajiv to tell us how to differentiate TAS from infection.
Respected Chairman, Co-Chairman, Convener, colleagues, teacher, and my dear friends, a very good morning to all of you. After a wonderful theatre day, having done about 10-15 cases, everything going on smoothly, the very next day you go to your office, you see patients dropping in with reduced vision and other symptoms, and you one after the other, and your reaction will be like this. But there are instances where people have thought of quitting doing surgery after seeing such cases. And some of them have even thought of quitting the profession itself. But at this time, you have to keep cool and show no reaction to the patient and apply your mind. If you apply your mind, have a careful examination of the patients, you can come to a conclusion and it can save a lot of difficulties. And before we go into the differentiation, let's see what is TAS as such. TAS is toxic anterior segment syndrome. TAS is an acute sterile anterior inflammatory reaction that develops about 12 to 48 hours after anterior segment surgery. When it is localized to the endothelium alone, we call it toxic endothelial cell destructive syndrome. Now, what are the causative agents for TAS? Intraocular irrigating solution, when the pH is altered or the osmolarity is altered or the ionic composition is altered, TAS can occur. Denatured OVD. Just go back and see whether you have started using a new batch of OVD. That could be the cause for the TAS. Intraocular medications with preservatives, topical ointments, inadequate sterilization of instruments, inadequate flushing of instrument, preservatives, bacterial endotoxin, and metallic precipitates have been attributed to the cause of TAS. So the incidence is about 1.887%. It is much higher than endophthalmitis. So most likely what you're going to see in your OP is going to be TAS rather than endophthalmitis. That is going to give you a comfort when you see the percentage. The cleaning and sterilization of instruments for cataract surgery appears to be the most important factor involved in many of the reviewed cases. So proper sterilization, cleaning of instrument is very, very important to reduce the incidence of TAS. And the use of enzymatic cleaning solution has been implicated in the cause of TAS. And of late, we are using a lot of ultrasound cleaners. It has been seen that gram-negative bacteria are growing in these ultrasound cleaners, which produce heat-stable exotoxin, which is attributed to TAS. So let's go into the differentiation, timing of the disease. TAS occurs between 12 to 48 hours after surgery, whereas endophthalmitis occurs commonly between 4 to 7 days. There are cases where endophthalmitis has been reported as early as the first day itself, but most likely it is endophthalmitis if it is on the 4th or the 7th day. Pain is very uncommon in TAS unless otherwise the intraocular pressure is very, very high. Whereas about 75% of the endophthalmitis patient present with pain. That is the EVS study says. Vision and projection is very, very important thing which we have to do, because at this time we may panic, we may not even look at the vision. You just keep looking at the eye. If the vision, in both the cases, the vision can be affected. But the projection as such is not affected in TAS in majority of the cases, because the posterior segment is not involved in TAS. Conjunctival and lid reaction is not involved much in TAS, whereas in endophthalmitis it is quite often involved. If you look at the clinical picture, it will be like this with chemosis and in endophthalmitis. Corneal edema, limbal to limbal edema, is the hallmark of TAS. That is because of the endothelial toxin, endothelium which gets destroyed, it causes edema, and it is uniform from limbal to limbal, whereas it is very much localized in endophthalmitis in the early stages. But as the disease progresses, the edema can spread to the entire cornea. You can see the difference in this picture. Even with an hypopyon of that much in endophthalmitis, the cornea is relatively clear compared to the TAS. Hypopyon is less common or less frequent in TAS, whereas it's quite frequently seen in endophthalmitis. The iris finding, pupil is usually dilated in TAS because of the increased intraocular pressure, whereas in the early stages, in endophthalmitis it is not involved. You can see that atrophic changes also in the iris in TAS, whereas in the early stages, the iris is not involved in endophthalmitis. IOP is high in majority of the case in TAS. It is normal in endophthalmitis in the early stages. B-scan will give you a definite clue towards the diagnosis. The vitreous is not involved in TAS, whereas in endophthalmitis it's very often involved, and you see opacities in the vitreous cavities. Therapeutic response is the defining test like what we do for to differentiate between TAS and endophthalmitis. Even frequent application of steroid drops, as frequent as half hourly if you apply, you can see the difference in the clearing of the anterior chamber and the cornea over a period of 2 to 3 hours, which will definitely clinch the diagnosis as TAS. And this is a rare case wherein an intravitreal injection was given and hypopyon developed, which responded to steroid very well, indicating that TAS can occur in posterior segment surgery or intravitreal injection also. Now look at this case. This presented the first post-op day with multiple cells in the anterior chamber and drop in vision, but the projection was normal. You can even look at the pupillary area where there is fibrinous reaction is seen, and pupil is small in this case. With topical steroid, the response was so drastic, within 2 hours the amount of cells started decreasing, and you can see the red reflex appearing very clearly at the end of 2 hours. The same patient on the third post-op day, the entire thing has resolved with steroid, clinching the diagnosis as TAS. Whereas when you give frequent steroids, the hypopyon increased in endophthalmitis. You can see the KPs appearing, and in endophthalmitis, this is the response we get in a very short time. From 10 a.m., the picture changed to what you see at the end of 4-5 hours. So caution is, limbal to limbal corneal edema is the hallmark of TAS. Infectious endophthalmitis should not be eliminated from the differential diagnosis until the patient's clinical response to steroid is obvious. And isolating the organism is the definitive diagnosis to differentiate the two diseases. If you see a picture like this, please don't wait for it. It is quite obviously an endophthalmitis, and you'll have to act very quickly. Thank you.
Thank you, Dr. Rajiv, for that comprehensive coverage. Next, we have Professor Atul Kumar talking to us about post-intravitreal injection endophthalmitis versus post-operative endophthalmitis. I can't think of a better person to speak on this topic when we face the problem of a cautionary note being issued by the DCGI on Avastin usage. Professor Atul, as the head of the RP Center, was leading from the front airways for restoring Avastin back to us. And I think dealing with post-intravitreal injection endophthalmitis is a major issue. And over to Atul.
Thank you for those kind words, Dr. Ramurthy, and fellow delegates to this wonderful city and convention center of the AIOS, and the entire organization. The entire AIOS and LOC has to be really commended for this very successful meeting. So before wasting any time, we'll go on to the topic. It's PIE, or post-intravitreal injection endophthalmitis, in short as PIE, or post-operative, and just comparing it with the post-operative endophthalmitis, which is classically seen after phaco-cataract surgery or even after vitreous surgery or endophthalmitis surgery. But the EVS basically is after the surgical post-cataract surgery endophthalmitis. So what are the points about endophthalmitis we need to know? It's basically endophthalmitis, inflammation of the inner layers of the eye resulting from an intraocular colonization of the infectious agents. We have an immune privilege in the vitreous, but sometimes the inoculum is so great that the inoculum overtakes the immunological status, or if the patient is immunosuppressed or has low immunity, then it depends on the inoculum, it depends on your immunity. The two things have to, if the immunity is high, even a large inoculum may not be able to cause endophthalmitis. And native flora may be present in the skin and everything. So when they take over because of certain problems of the virulence of the inoculum, or because of poor immunity of the individual, can the endophthalmitis occur. So it causes severe orbital or ocular morbidity and visual loss. Our recent concern, as Dr. Ramurthy just said, is the post-intravitreal cluster endophthalmitis, where we had a number of such incidents all over the country in the last year or so, which kind of settled down now, especially after intravitreal Avastin, this occurred. A little bit of why this occurs after post-intravitreal injection is that there's a dramatic increase in the number of intravitreal injections performed, possibly the most commonly performed intraocular procedure, about twice that of cataract surgery in our country. We don't have exact figures, but maybe even much more than that. There are confirmed reports now of series of cluster endophthalmitis from various regions of our country. This is what Dr. Ramurthy was telling you. There was a number of cases which occurred, and finally the Director General of the Controller of the Drugs Controller of India decided, in consultation with the Ministry of Health and Family Welfare, that the Avastin causing cluster endophthalmitis had to be kind of given a slight ban, in the sense that there was a drug alert issued by them, as a result of which we could not use Avastin for quite some time. And it was finally in March. It happened in Jan 2016, and 2 months there was Avastin ban, so we could not use Avastin. And finally in March, with great difficulty, they issued an order. Yes, we could use it, But we have to have proper guidelines, informed consent, and we shall be totally responsible for whatever happens. So with all those understandings and the fact that it's a cheap drug, it's affordable to the masses, they agreed to do it. But those things which they've said about the guidelines have to be strictly followed. The AIOC, the VRSI and the AIMS decided to bring out the guidelines have already been circulated during Dr. Ramurthy's time. And cluster endophthalmitis is something which is difficult to define, but generally more than 5 cases operated on a single day in a single theatre in a single center. So it's usually occurs because of the high risks involved due to this definition. Now, NPCB data I was going through has not much on cluster endophthalmitis. Recently, 2006 to 2009, there were cluster endophthalmitis in the various months, and 2 to 3, 4 clusters did occur, but these are post-cataract. We don't have specific data of how many centers were involved for cluster endophthalmitis due to intravitreal injection. The infection percentage varied from this MPCB data from 7.7%, that is 35 of 450 eyes in Guwahati, Assam, to 100%, 23 or 23 in Lucknow. So it can vary. It can be the entire group. Like in Indore, I saw there was about 60 eyes who had got cluster endophthalmitis after cataract surgery. So because of this, there's been a large-scale concern, and the press also raises the issue in a big way. So we've got to understand what causes this. It's either due to a sterilization failure or contaminated surgical supplies. There's a breach in our standard operating procedures. There's a surgical sterilization failure. Or the surgical supplies which are given to us are contaminated. The drug is spurious or it's counterfeit. There's improper storage of the drug. That's a lapse in cold chain that you have to maintain at 4 degrees the Avastin. In case same vial is used more than once, multiple punctures, then it's something which we can avoid. Failure of asepsia sterilization technique in the theatre can be another major cause. And contaminated OT, of course, comes with it, because if OT is not properly sterile, as been told to you in the first 2-3 lectures, it's very important that that should be maintained. There are certain characteristics of post-intravitreal endophthalmitis, intravitreal injection endophthalmitis, or PIE compared to POE. So, post-surgical endophthalmitis or POE, the cataract endophthalmitis, will present either fulminant within 4 days, or acute 5 to 7, or chronic more than 4 weeks. The time period of occurrence of the post-injection of endophthalmitis is, in turn, can be as early as 24 hours. The patient gets an intravitreal injection today of Avastin or an intravitreal steroid. Next day, he may come to you with pain and some hazy vision. His cornea is a little hazy, his glow is not good. And then you got to err on the side of treating. The low threshold of treatment. We have to have a low threshold of treatment. Don't just think it's some reaction to the drug, maybe something sterile. It may be sterile, but you have to treat it aggressively with intravitreal injection, at least one intravitreal injection. The most frequent pathogen reported in post-intravitreal endophthalmitis are gram-positive. That is post-intravitreal injection endophthalmitis is gram-positive, including coagulase negative staph, 78.3. Predominant pathogen in post-surgical, which is the post-cataract, is staph epidermidis also. But what is of concern is the gram-negative staph viridans. It's a component of the human fluorides present in the buccal mucosa in the saliva. As is reported, we present 3 times more often in the post-intravitreal injection endophthalmitis. And this is because it's a droplet infection when we talk or we don't wear a mask that it happens. And this has been seen about 3 times the number in this PIE endophthalmitis. So it's very important that you have to keep yourself totally quiet and also wear a mask. Now, how common is cluster endophthalmitis? Post-cataract incidence is 0.09 to 0.33. These are Western figures. Now, we haven't collected data from 20-30 centers. It may be possible, but probably AIOs can collect it. Incidence after intravitreal injection varies from 0.016 to 0.026. It's less, but the risk is very high. Why is the risk high with intravitreal injection? It's most commonly performed procedure. In India and the US, they have data. There's a dramatic increase in the number of injections given annually. Anti-VEGF steroid injections about twice that of cataract surgery. Multiple patients, multiple punctures with the same vial in one OT. Risk of cluster is extremely high. Bilateral injections are not recommended, and as per the guidelines brought out by us, it's definitely not recommended on the same day. What are other risk factors and recommendations? End of incidence is lower. This is something, maybe just a finding which they got in France from the study of 25 centers which they had post-intravitreal injection endophthalmitis. They said it was lower in eyes with CRVO, but they found it more in diabetic eyes because they feel it's because of impaired immunity. And neovascular AMD, the aging patient has probably got waning immunity, old age. So what they said was treat diabetes prior to injection, but of course, these are patients who are at higher risk, the AMD and the DME patient, diabetic retinopathy patients. Now, post-intravenous injection endophthalmitis is not affected by bladed eye speculum use, conjunctival displacement, the hemisphere of injection, or the type of agent. So that does not make any difference. Post-injection topical antibiotic does not reduce the risk. Let's just take half a minute. Topical antibiotics, there's lack of evidence to support pre, or post-injection topical antibiotics. Consent is a must, has been told to all of us, and that consent you have to take. Now, this is just to tell you exactly what I want to tell you is that use 10% for the skin, 5% conjunctival sac betadine lotion. Wash it, you apply it over that. The recent evidence supports use of povidone iodine, last applied, no lid scrub. Don't scrub it. You release microorganisms. Avoid talking, use mask while giving the intravitreal injection, step viridins infection. Use of sterile drape and speculum, lashes tucked in, sterile speculum. Mark with calipers, inject 3.5 to 4 millimeters from limbus, preferably in inferior temporal quadrant, use a 30 gauge needle. And the drug procurement should be from a certified Roche dealer, check authorization letter, and maintain the cold chain. Check with dealer. The cold chain is very important, and the Avastin is usually stable for about 45 days as per reports from the West. The most important option which you can have for creating a number of vials is that you create a number of syringes by puncturing a vial under a laminar hood. A laminar hood passes sterile air, a flow of sterile air in a laminar fashion through to a HEPA filter. It's got a HEPA filter. It directs air into the HEPA filter. It flows out from the HEPA filter in a laminar fashion, and it cleans that area where you're preparing the ampule. So it's class 10 facility you got. Very clean. So that's the best they say. And this is the class 10 facility which we have, the laminar hood, under which we prepare. This is a class 10, and the room is class 100. So these classes are well given. The clean room class facilities, you can all read it up. And these are single dose ampules we prepare at RP Center. The last slide I just want to tell you, if you want to compare the two, POE, post-cataract surgery endophthalmitis, or post-intravitreal injection endophthalmitis, the incidence can be less in intravitreal injection endophthalmitis as per Western figures, but we may have different figures. The risk is extremely high. This we totally agree. The duration may vary from 4, 5 to 7 to more than 4 weeks, but here it may be early as 1 day, just like TAS. So if you got vitreous, but it's got a history of intravitreal injection. The outcomes are very poor. The visual outcomes somehow are very poor because of gram-negative infection often. So you have gram-positive here, but gram-positive, step viridins because of human flora. It's very fulminant. They also get to see Enterobacter and Lactococcus. And treatment as per EVS for the cataract patients, but for the PIE, you've got to slightly modify it. You can't give 2 or 3 intravitreal injections. 1 intravitreal injection, early PPV, especially for persistent vitritis, maintain low threshold for treatment. So this is one thing I'd like to get across to you, these points, salient points, and thank you so much. This happens to be our Golden Jubilee year, and we welcome you all to our scientific program, which is on 11th and 12th March at RP Center at the Ames Auditorium.
Thank you very much, Professor Atul Kumar. You have conveyed the message that intravitreal injection should not be taken seriously, should be given as much importance as any other intraocular surgery. Thank you so much on that. I would invite Dr. Lalit Verma to speak on management principles of endophthalmitis. There can't be anybody better than Dr. Verma to cover this. He's looked after our scientific interests for such a long time elegantly. We would like to hear all the new concepts on the management of endophthalmitis from you, Doctor.
Thank you, sir. Thank you, Dr. Ramamurthy, for having me here. You see, despite good OT design, good OT technique, prophylaxis, ENDOPH still bothers. And not only here, but across the globe. That is the reason EVS in America also could collect 420 cases of endophthalmitis over a course of 5 years. The key words to my mind are suspect. Don't sit over it, then react, and then act. You see, if you follow this, and you follow what Rajiv told, differentiate between TAS and this, I think half the job is done. So early prompt management, irrespective of Saturday, Sunday, holiday, is what yields gratifying results. Believe me, it's a disaster. Like Ramamurthy had said in the first slide, that to an operating surgeon, it's a headache for him. If not managed in time or properly, end result is this. So having diagnosed and differentiated endophthalmitis, I'll take you to a couple of situations. The first situation I would like to highlight is you have a more than usual AC reaction like this, and like Dr. Rajiv had said, differentiate. And these are the key features which I already highlighted. I'll not go into details. From TAS versus infection, try to differentiate as far as possible. And once you say it is TAS, load this patient with steroids. Load means give him 1 hourly steroids round the clock, give him intravenous, oral, but follow up closely. That is the key bit. Follow up closely. The moment it worsens, shift to interval injections. If it improves, continue steroids for a long time. And I'll show you one example of each of the situations. This is one patient who came to us, unusual reaction, hazy media, treated with steroids, follow up every day, if not twice a day. You see at the end of the result, this proves, like you were saying, therapeutic challenge. At the end of 2 weeks, 6/6 vision. Situation number 2, the diagnosis is towards endophthalmitis. Immediate interval injection. Do not ask Saturday, Sunday. Sunday also go and give. What to give, when to give, how to give, I think all of you know. But when to give is earlier the better, as I said. Do not wait. Or if you are following a patient of TAS, the moment it worsens, please give the injection. And which to give again is not a controversy now, because we treating empirically, choose one for positive and one for negative. And at the present, the initial combination by everybody is Vanco and Kefta. And this is the dosage required. And we can't memorize. Please take this chart, which was distributed by AIOC long time back, twice. And this chart should be hung onto the OT wall. And any time you have to give 2 injections, you have to decompress, because I cannot take in 2 injections. Therefore, you have to decompress. The best way to decompress is vitreous biopsy. Short of that, you can do aqueous paracentesis also. But the disadvantage of aqueous paracentesis is that the microbial yield is less. And always have 2 injections prepared and use the 30 gauge bore needle for giving injection, and prior mixing is not recommended. We do not forget the topical adjunctive treatment, although EVS said that parenteral antibiotics do not have a role, but that was the time when all these fluoroquinolones were not available. But after that, we still give these patients. More important is follow this patient. Any worsening after intravitreal injection, subject this patient to microincision vitreous surgery. If no worsening, this patient has become stable. That itself is a good response. This patient will improve. This is one example of patient who was given intravitreal vancomycin. After a course of few weeks, this patient has come back. Situation number 3 is that you have given an intravitreal, but some of the response is not as good as this gentleman. So what we will do? If the culture sensitivity report says different organism or different sensitivity, you can give. But otherwise, I for one do not repeat the injection and straight away go for a MIVS. Situation number 4 is that patient does not respond at all. So our patient is very severe infection. So these patients are candidate for vitreous surgery. And once you are doing vitreous surgery, the concept of core vitrectomy is no longer valid. You do as much vitrectomy as possible. Do a depression vitrectomy, take away every bit of infection from the eye. And this is what we call radical kind of vitrectomy. Even at the cost of peeling of the hyaloid or risk of creating a break, please do a total vitrectomy. And this is one small video for what is being told as total vitrectomy. First job is always to clear the anterior chamber. Because if you don't clear the anterior chamber, vitreous surgery being specific based on visualization only, that you can't see the vitreous well. So tease off this fibrinous or pupillary on the surface of the IOL, and after that, then only you can turn on the infusion and then do the proper vitrectomy as is being shown here. This is one patient who has had total vitrectomy done, and at the end of it, we injected silicone oil. Whether IOL should be removed or not, majority of the patients we tend to retain the IOL. But however, if it's a very severe infection, meaning thereby that the ora serrata is also involved, or it's a recurrent infection or fungal, then I try to remove the IOL, because otherwise we can't do a complete job. This is one patient who presented with corneal abscess, and we had done IOL removal in this patient because could not see anything for at least 45 minutes down the vitrectomy. You see, this is the corneal abscess here. The infection has entered through this. And once we are doing vitrectomy, this IOL itself, presented in the wound itself, and the IOL was taken out. And once the IOL is out, Then you do a complete vitrectomy after suturing the wound. Take away every bit of infection from the anterior chamber also, and try to, remove this connection from the corneal abscess towards the pupillary area and the vitreous cavity. Having sutured the wound, do a depression vitrectomy as is being shown here. Keep doing in all the areas of the eye, and then inject silicone oil. And this was the end result of this patient. Situation number 5 is of patient of fungal endophthalmitis, where you suspect fungal that signs are more than the symptoms, or patient has not responded to the injection. And here, although voriconazole is available, but by and large, this patient require vitreous surgery and multiple vitreous surgery, and sometimes they may require twice in a week amphotericin B injections also. And this is one small video of a proven fungal candida infection, where multiple vitrectomies had been done. But what was not done in previous vitrectomies was this removal of this hyaloid face, because all these pus pockets, what you see, are subhyaloid. So do not hesitate to remove the hyaloid membrane in such patients who presents with recurrent kind of infection. You see, I'm trying to tease with the soft tip needle, and here comes the hyaloid, where you remove this, and then this patient goes into remission. This is an example of a patient of fungal endophthalmitis. Situation number 6 is a chronic, where you suspect P. acne kind of endophthalmitis. Here we have a graded approach. Usually intraocular antibiotic will not help. You have to inject where the bug is there, that is within the bag, vancomycin, or a lot of these patients require capsulectomy. This was one patient of suspected P. acne, underwent vitrectomy with capsulectomy and in the bag vancomycin. This situation I will not cover because Dr. Atul has very fantastically covered Avastin and any intraocular injection, Ozudrex. The last is about when cornea becomes so bad, then you have to take the help of cornea colleague and do this video shows a temporary keratoprosthesis. This is a cornea melt patient where this button is being cut by the corneal surgeon, and after this has been done, you put in a temporary keratoprosthesis, suture it, and then do the vitrectomy. This is a temporary keratoprosthesis in place, and then you do the vitrectomy, and after that, put in the corneal button. So this is how to tackle. That is the most difficult part, and what we advocate is one person should do talking to the patient or the media, but please maintain in writing, document all your findings. This will help you to save court of law. So just to summarize, I have tried to cover up when and how to give injection, what to do if there is no response, what to do if there is a very severe infection, fungal endophthalmitis, chronic endophthalmitis, and the concept of avoiding limbal entry, radical vitrectomy, and do not hesitate to peel hyaloid. Silicone does help in severe cases. So keywords are always suspect, react, and act. That yields the best kind of results in these patients. Thank you very much for your attention.
Thank you, Lalit. Now we'll come to the last talk before the panel discussion, and it will be by Dr. Ramurthy, D. Ramurthy, whom you all know. He's just been your president till yesterday, 2 days back. And he'll be talking about dealing with a single or cluster endophthalmitis, the socio and medico-legal aspects. Very important topic.
Thank you, Dr. Atul. All my co-instructors have taken you through steps of endophthalmitis, how to avoid it, how to treat it. But if you have a case, how exactly do you deal with the social and medico-legal implications? I think that's one area where we ophthalmologists are not too conversant with, not too comfortable with. Right away, let me tell you that occurrence of endophthalmitis is not a crime. It's not something for which you are going to be jailed. But at the same time, you are responsible for it, and you have to prove it to your peers, to the court of law, to the general public, to the press, that a standard of care and best practice patterns have been followed. So there are things that you do before doing the surgery, and if you have an endophthalmitis, how exactly do you deal with this? Let's look at this landmark judgment passed by the Supreme Court in 24-309, where the laws of negligence were enunciated. Basically, the laws of negligence are not just applicable to doctors, it's applicable to lawyers, it's applicable to auditors, it's applicable to architects. And what's necessary is that the person dealing with the case must possess requisite skills. This does not mean that they have to be extraordinary surgeons. Average surgeons is what they require. But obviously, if it is a trainee surgeon who is operating, it should be done under supervision. Reasonable degree of care and caution should be exercised, like all the various factors about the preoperative preparation, the care of the operation theatre, etc., which have already been covered. You do not guarantee results. Do not hype up the kind of results that you're going to give. Glass-free vision, next day surgery, maybe next day back to work, etc., which normally most of us do, may land you into trouble. And doctor's contribution to the mishap must be established, and the proof of doing this is based on the complainant. Basically, it's not the accused who has to prove to himself, but the person who is giving the complaint, whether it's in a court of law or whether it's in a consumer court, who has to prove beyond doubt there is negligence that is there. An error of judgment or an accident is not tantamount to negligence. Your hands need not shake that what happens if I have a PC rent in this patient. Just because you had a PCR, all of us do have it, and the patient ends up with endophthalmitis, that does not mean that you can be punished for that. What if you receive a legal notice? Do not panic. Do not compromise. That's most important. Don't call the patient and the relatives and try to enter into some kind of a compromise, because the demands may be huge. This might have to be done at a later point of time, once certain proceedings have carried on in a court of law, just to finish the case, but not at the initial step. Read the legal notice carefully, and as soon as possible, do not refuse to take the notice. Please take it, and then subsequently you can respond that I categorically deny and refute the charges mentioned in your notice. I'll be sending you a detailed reply soon. This is something you do well to do within 48 to 72 hours. Inform your insurance company or IMA in case you are covered by insurance, and get the help of a good and seasoned consumer case lawyer. This is extremely important. Do not compromise on the costing in this. Your insurance company might be responsible for doing this, but make sure you get the right kind of lawyer, because if you get the wrong person, it might be trouble for quite some years to follow. Give a proper reply drafted by a lawyer. Normally it's expected to be sent within a month's time, but you could take as long as a month and a half to do this. Case sheets form a very important document in law litigation cases, and don't try to tamper with the kind of records that you are maintaining. Basically, we have shifted over to EMR completely. In this situation, what we have is, at the end of the day, no longer we can change any records that have been entered into the case sheet without the TCS getting involved, which is a major process. So having such a system in place gives a lot of legality, a lot of weight to the kind of records that you maintain. Consent is extremely important, but just because you have taken consent, that doesn't absolve you of all the liabilities that follow if an endophthalmitis does occur. Consent must be in a language that the patient understands, and it is not something that you take just a few hours before performing the procedure. It has to be definitely signed by a patient, attender, and a surgeon. It's quite a problem to make sure that it is done by all these three people, but now we have made it a routine. I think you will do well to do that. Related complications must be mentioned. Your informed consent must mention that endophthalmitis, delayed recovery, poor vision, etc. are possibilities that might occur after the surgery. Discharge summary must be given to the patient. It must be signed by the consultant himself and not by a junior doctor. Post-operative instructions in the language the patient understands must be typed and given. And if you also, both in the instructions that you give in the form as well as what you tell the patient orally, it has to be told to the patient that do report immediately if you have an untoward symptoms. Most importantly, document what you do. You might be doing everything right, but in a court of law, it's extremely important to prove it to them that you did it right. For example, we routinely do cultures every 3 months on about 15 locations in operation theatre, and this is you can see the punch marks over there. These are the kind of NABL accredited labs which give these culture reports, and these are filed and kept ready in case the need arises. Once a month, we do a Bovidec test on our horizontal autoclaves. This tells us about the vacuum that's maintained. Biological indicators are also used once a month. Again, the records of all this is maintained. And as far as the ringer lactate solution, the BSS that you use, the viscoelastics that you use, the batch number of all this is noted down. These are all actually from the documents that is maintained in my operation theatre, and I was happy to see that they are doing such a thorough job of it, and these are all available in case the need arises. And again, whatever implant goes in, the intraocular stickers, the implant stickers must be there for each individual patient. This is a separate register that is maintained, and this again tells you the kind of care that you are exercising. In case endophthalmitis does occur, then of course all those things that you did earlier does help you. But then most importantly, you have to do a complete examination and record each time. That's most important. And in case view is not there, get a B scan done and visit the patient multiple number of times. No telephonic consultations. You might have a counselor who handles your helpline number. She should not be saying just increase the number of steroid drops, just add an antibiotic. Definitely you call the patient back for a consultation. And in case the patient is from a far distance, it might be a good idea to ask the patient to go ahead and have a consultation with a nearby ophthalmologist. Please document that. And maximum liability arises from a delay in diagnosis or treatment, including a delay in referring the patient to a vitreoretinal colleague. So in case you are a single practitioner, you're purely an anterior segment surgeon, even if there is a doubt, go ahead and maybe give an intravitreal injection if the patient is going to take time to reach a vitreoretinal colleague, but give an intravitreal injection and subsequently refer this patient. I think today, for a cataract surgeon to know how to give an intravitreal injection and the dosage, the exact way to do it is as important as knowing anterior vitrectomy if you're doing phacoemulsification. What if there is a cluster infection that, as was mentioned, is occurrence of 5 or more infections in a day, or the occurrence of repeated infections? If cluster infection occurs, obviously the onus becomes higher. Inform the authorities, institute infection control committees, inform All India Ophthalmic Society. We have provisions for a legal cell and to assist you. This is not something you keep under wraps and get into trouble later. It is not some crime you have conducted. It could happen to any one of us. Take inputs from all the doctors and OT staff, have a meeting, review the sterility procedures, take multiple cultures from the operation theatre, note down the patch number of solutions that have been used and culture them in case more solutions which have been unopened from that batch is available. Seal and keep all solutions in safe custody, and most importantly, you owe it to your fraternity. If you find contamination of any of the solution, inform the concerned company and make sure the information gets around. You can inform AIOC and that will take care of it. Consider temporary OT closure. It's a big crime if you have had a cluster infection and you continue to use in the operation theatre and get recurrent infections. Call upon external agency to review the procedures. Now, dealing with the patient and relatives, obviously you promise the world to the patient. This is what she or he came expecting, and this is what they see on the first post-operative day or 5 days later. There is reason for disappointment, resentment, and anger, which is natural. Suddenly, you become from a hero to villain. So most importantly, talk to the patients, explain in the most simple terms about the complication that is there, how we are going to deal with that, explain the steps that's being taken, visit the patients frequently, maybe 2 or 3 times a day. Appear confident. Give them an impression that you are under control. If you appear shaky or not too sure of what needs to be done, obviously the patient is going to go elsewhere. Getting a second opinion is also a great idea. Dealing with relatives, be patient. That's most important. Suddenly, people who are never interested in the patient turn up multiple times to inquire what's going on. Obviously, you owe it to them to reassure them and say the same thing over and over again. Do not say different things at different times. And in case media coverage does occur, and this is the kind of coverage that has occurred just in the last 1 year, media, as we all know, is an essential evil. And what they want is to sensationalize what has happened. They want news. They want their papers to sell. And there's natural sympathy for a sufferer and to blow it up. The thousands of cataracts that you did with good results are of no value at that point of time. So at this point of time, please do remember the media coverage is only of value for that particular day. There are enough of politicians and enough things happening around the world to take the media glare away from after that 1 or 2 days. Do not issue repeated clarifications and counter allegations. That will only keep the issue alive and keep the focus of attention on what's going on. And completely avoid social media. Even if someone has written about this incident in social media, do not respond to this. I think stick to facts, be calm and transparent, talk to many reporters, simplify medical complexities. Of course, it's very easy for me to put all this in a slide, but when you're faced with a situation, it's obviously a difficult proposition. And at this point of time is when association, when senior colleagues, senior professionals should step in, and we should face this problem together. I think finally, I think at the end of all these presentations, occurrence of endophthalmitis is inevitable once you do enough number of cases. It's a harrowing experience, but one can come out of with the head held high with a lot of learning if we handle it properly. Thank you so much for your kind attention. We have about 5 minutes. Yeah. I think we have about 5 minutes. Any questions from the audience?
Yes. And one question, sir. One question.
Yeah.
Sir, you have one point you have mentioned that, that every 3 months this culture should be done. Sir, in the as per latest guideline of the NPCB, they are advising twice in a week. So, what we should?
Twice in a week?
Yes, sir.
Twice in a week?
Latest guideline is twice in a week.
I don't think that's necessary. Actually, Dr. Ravindra mentioned that.
I think it's once a week.
No, sir, it is twice in a week.
Okay.
I'm very much sure.
Okay. Normally it's supposed to be once a week, but I'll just check it.
Yes, sir.
I will look into it.
Once in 2 weeks, sir.
Must be once in 2 weeks. Because maybe once in 2 weeks is also
twice
okay.
in a week.
Okay, we'll check on this and revert to you.
Okay, sir.
Because like in ROT it's once a week, so it may be NPCB said once in 2 weeks.
Yeah,
as we are seeing that moxifloxacin is the supersession antibiotic. So can we use it in the vitreous route or not?
He's asking whether intravitreal moxifloxacin can be used.
Yeah, can be used.
What is the dose and how to give?
Interval moxi, I think 125.
It's 1.25 milligram.
In the insulin syringe, how much I shall take to push it?
How much?
How much dagger indications?
The 30 gauge needle, sir.
30?
30 gauge.
Achha.
Tuberculin syringe 30 gauge.
Thank you.
Sir, any disadvantage of intracameral antibiotics?
Sorry?
Any disadvantage of intracameral antibiotics, prophylactic antibiotic?
It can cause TAS actually.
Sir, somebody has shared his experience that he has got more cases of corneal edema after intracameral antibiotic. Do you expect this?
Shrais is here.
That's really not so, in the sense that we have been giving intracameral antibiotics for quite a long time, and we have not experienced this. We are not even very definite about the amount of solution that's injected. I think Shresh, you can.
Shresh, any disadvantage of intracameral?
So, at least in the multiple studies which have been published, including the 600,000 case series which was published, there was not a single allergic reaction which was attributable to the intracameral injection itself. Of course, intracameral vancomycin, however, has several reports of incidence of HORV, but moxifloxacin, none has been reported.
And sir, one more question regarding the consent. Should it be taken a day or two before the surgery, or as everybody, most of
It's ideally taken at least a day before the surgery. Ideally taken a day before the surgery.
And should we get it signed again at the time of surgery?
No. Once signed, I mean, if you're taking it the day before, that's quite adequate.
For intravitreal injections, it would be the same day. Intravitreal injections, same day consent.
Yes, sir.
No,
Thank you.
Normally, we give the consent form to the patient, let him read it, let him be happy, then he signs.
Yes.
It should not be in a hurry that same day. वो कहते हैं उसी time sign करा लिया मुझसे.
Yes.
That should not happen.
You know, when you said the word hurry, you should never be in a hurry. It's always, that is what we have to develop anyway. But coming to my comment, you said about the immediate necessary evil. There is a book almost written 30 years ago. It's called Media, the Second God. Think about it to the administrators. I'll send you a copy of that. It is from the internet. Media can be second God. There's a book was written 30 years ago by Schwartz.
We don't allow media to become second God, sir.
You don't?
We don't allow media to become second God.
Doctor,
allow me a question.
Doctor, work with them.
Dr. Raju is talking of media in United States.
The media in India is entirely different.
Absolutely.
Dr. Amurthy.
Yeah.
Actually, this INABH guidelines, they have been discussed during this meeting also, and there is some book which is available there. But yesterday it was told that they have accepted only a minimum of 260 square feet of OT space. Whereas today in our meeting it was said that between 150 to 200. The NABH people say that there is an advocacy, but it's not gazetted or it's not notified. So how do we kind of, what is the actual position for the guidelines?
If you're looking for NABH approval,
Yes.
then definitely the kind of minimum OT standards that's needed is what is given over there.
Okay.
But what's mentioned over here is what could do well for a normal ophthalmic OT. Previously, what was necessary was a 20 feet by 20 feet OT. We have considerably brought this down. The OT height is also less now. HEPA filters is not needed. And to my knowledge, though the assessors look at all the different factors, just because the OT is smaller by a feet or two, they generally do not make a big fuss about it.
I see. Thank you.
But it's a good idea to stick to these guidelines. I think that brings us to the end of this wonderful national symposium. I thank all my co-instructors and also the abundant audience who turned up for this. Thank you so much.
हेलो एक बैंड ऑप्थेमोलॉजी का प्रोग्राम है जिसमें जो ये चिंता आप लोगों को हो रही है, स्ट्रेस हो रही है, उसके ऊपर कैसे ओवरकम किया जाए, क्योंकि एंडोप्थेल्माइटिस इन्फेक्शन कॉम्प्लिकेशन हर जगह होती है. तो इसलिए दैट इज द थिंग, अगर दैट इज कॉल्ड मिड ब्रेन एक्टिवेशन, थर्ड आई, एंड देयर साइंटिफिक एविडेंस. अगर आप धीरे धीरे उसको अपनाएंगे, उसको अपने जीवन में लाएंगे, तो आपके अंदर हो सकता है स्ट्रेस कम हो. चिंता चित्ता समान है. तो जो लोग इंटरेस्टेड है वो 1:30 बजे यहाँ बैठ जाइए. बैंड ऑप्थेमोलॉजी में कार्यक्रम है. धन्यवाद.